Hi, my name is Romy and today I'm here to discuss about a disease called renal calculi with a case study of a person suffering from this disease. When urine contains a high amount of mineral and salt, the stone starts to form in the kidney or lower down in the urinary tract is called renal calculi. The size of these stones can vary. Renal calculi is also known as kidney stones or renal lithiasis. There are various types of kidney stones. First is calcium oxalate, which is the most common type of kidney stone, which is mainly formed of calcium oxalate and sometimes calcium phosphate. Secondly, uric acid stones, which forms because of high amount of uric acid in urine due to the high protein diet. Number 3 is struvite stones, that is reasonably caused due to urinary tract infection as some type of bacteria secretes an enzyme. Finally, cystine stones are very uncommon and occur in people with a genetic disorder where the body makes too much of amino acid cysteine naturally. Some of the causes of kidney stones are low urine volume that can cause due to dehydration, improper diet like high intake of calcium or high animal proteins, bowel conditions causing diarrhea and surgeries, pH imbalance in urine, urinary tract infection, heredity can be a risk factor for kidney stones too, hyperparathyroidism, and obesity. Normally, the treatment of kidney stones depends on the size, type and location of the kidney stone. If the stone is small and is of tolerable pain, it can be treated by drinking lots of water and wait for the stone to pass through urination. If a person has a urinary tract infection along with a kidney stone, the healthcare provider will prescribe an antibiotic. Having an infection along with the kidney stone can be a life-threatening, so it is important to treat the infection as well as the kidney stone. If the stone is too big to pass and is causing a lot of pain, the physician may suggest a special procedure that is done in a hospital to remove the stone. Number 1 is shock wave lithotripsy. It repeats the firing shock waves on the stone, causing the stones to break into small pieces. Afterwards, small pieces can be passed out through urination over weeks. Number 2 is uteroscopy. It uses a uteroscope into the bladder, up to the ureter, into the kidney and breaks the stone into small pieces through laser and is replaced by the temporary stent. Number 3 is percutaneous nephrolithotomy. This is a surgical process where nephroscope breaks up the stone and suctions all the small pieces out. A 33-year-old white man, Rod, who works in construction, introduced to the emergency department with serious and weakening stomach pain. The patient portrayed the pain as colicky and diffuse all through the anterior stomach wall with radiation to his back. The pain was exacerbated by walking and mitigated with rest. He referred vomiting, however, he denied any chills or night sweats. He had no history of kidney stones. Rod had no medical conditions and was not consuming any medications. He denied of any alcohol, tobacco or drugs consumption. The nephrons, mainly glomerulus, filters blood and all other minerals are removed from the blood and flow down through Bowman's capsule. In patients with certain inclining factors, there is an expansion in the danger of these minerals meeting up to shape a crystal. The crystal can develop after some time as debris, adheres to the crystal and further crystallization occurs. The crystal can go out of the nephron and remain in the renal papilla, ducts or other different parts of the urinary system and develop. Moreover, it can break and go through the framework and get stuck. The most likely mechanisms include the possible presence or abundance of substances that promote crystal and stone formation, a possible relative lack of substances to inhibit crystal formation, and a possible excessive excretion or concentration of salt in the urine which leads to supersaturation of the crystallizing salt. In Rod's condition, he is used to drinking not enough fluids and eating a high oxalate, protein and salty diet which caused him to have too little urine or too much oxalate which crystallized forming stones. Basically, urine contains chemical that protects oxalates from sticking together to form a crystal. Some additional information that was asked to Rod before his treatment was about his family history, medication he is taking, if he had pain during voiding, and his diet plans, which revealed that his father died because of renal failure, his mother has hypertensive, and one of his brother has a history of renal stone which passed suddenly. Also, he was fond of high oxalate and protein food like red meat, chicken, oranges, grapes, and he is habitual of taking less water. The risk factors for Rod were dehydration, imbalanced diet or his poor dietary habit, outdoor level intensive as he works in construction field, his family history, and his high blood pressure. On physical examination, he was 1.74 meters tall and weighed 69 kilos. His blood pressure was 155/95 millimeter of Hg, pulse rate of 79 beats per minute, and respiratory rate of 23. And his temperature was 36.7 degrees Celsius. The pain was treacherous in the beginning and had an intensity of 10/10 on verbal pain scale, which diminished to 8/10 after giving of Toradol and morphine meds in the emergency department. His pain was steady, enduring 3 hours in span, and he had 2 scenes of vomit since its beginning. He did not display any signs of edema or nausea, abdominal discomfort, or indigestion. His abdomen was soft with diffuse tenderness which increased over the right lower quadrant. The right and left kidney measured 10.2 cm times 6.3 cm and 9.8 cm times 5.6 cm craniocaudal and transverse respectively. Renal function test revealed an elevation in uric acid and serum calcium. An ultrasonography was performed and uncovered mild hydronephrosis. A non-enhanced computer tomography was then performed and demonstrated a 9 mm hyperdense image in the left ureter and 8 mm hyperdense picture in the right ureter topography. As the anterior abdomen pain commanded the clinical introduction of Rod, he was thought to have an acute stomach condition, which led to performing an abdominal ultrasonography before CT scan. The main goal is to discharge Rod with nil pain, remove stones without infection. The nursing goal is to decrease pain at a manageable level within 3 hours. The nursing assessment is to control pain by giving Rod around-the-clock pain medication, then PRN medication. The second nursing diagnosis is to maintain 3 to 4 liters of oral fluids per day unless contraindicated to decrease the risk of infection. The increase in fluid intake increases the pressure that helps move kidney stones and monitor for any symptoms of urinary tract infection. Also, strain urine and examine for the stones. The oral intake and output should be closely monitored as the goal is to make urine clear upon discharge. As the patient is consuming lots of fluid, there needs to be close observation to confirm the kidney is filtrating enough water based on intake. And keep Rod as mobile as possible and try to avoid supine position for a long time. There are some complications of kidney stones if left untreated. It can block the ureters or make them narrower. This increases the risk of infection or urine may build up and put added strain on the kidneys. Usually, these stones block the flow of urine, causing hydrostatic pressure within kidney, increasing pressure in Bowman's capsule that will decrease the functioning of the kidney. Also, it can cause damage to the nephron, causing renal failure. Stones also increase the risk of urinary and kidney infection, which can result in germs spreading into the bloodstream. Some other complications are urosepsis and urinary fistula formation. All the complications are rare because most kidney stones are treated before they can cause complications. Rod was presented with 8 and 9 mm distal ureteral stone bilaterally, which is unlikely to pass spontaneously, so the doctors offered him ureteroscopy. After the surgery, he was left with a double J stent at both sides to be removed at follow-up. These measures have provided him immediate relief of the symptoms and 36 hours later he was discharged. The stone fragments were sent to analysis and he is currently attending a nephrologist for clinical control of idiopathic hypercalciuria. The aftercare guidelines for Rod is to educate him about staying hydrated, limiting the intake of animal fats, avoiding intake of high oxalate food, and avoiding food high in purine. Also, explain him about the importance of exercise. The case of Rod, who was determined to have a new nephrolithiasis, was calcium oxalate stone. Finally, this is the end of my presentation. All the comments will be much appreciated. Thank you.